When I was at home preparing this talk, my husband, who is a slightly off-the-wall psychiatrist, said to me, the title of this talk could have been written by a Daily Mail person, because often you have someone thing in the Daily Mail where they say, this thing is going to cause cancer and it's going to cure cancer at the same time. So he's suggesting that I'm going to sensationalise everything about fibrinogen, but I'm not. I'm just hopefully going to provide you some measured evidence around the role of fibrinogen in acquired coagulopathy. So why is it important, and why are people paying more attention to what happens in acquired coagulopathy and major hemorrhage? Essentially because it is one of the leading causes of death worldwide. In the setting of trauma is the leading cause of death in adults under the age of 44 across the world, and the primary preventable cause of death is bleeding and its consequences. Postpartum hemorrhage is the leading maternal cause of death worldwide and is the third leading cause of death in the UK. Not only does it cause high rates of mortality, it causes high rates of morbidity associated with it, and the cost to healthcare across the world is high. Not only are there risks associated with the bleeding, but there are risks associated with the transfusion that is given to patients, and across all clinical settings where patients have major hemorrhage, there is increased risk of mortality and morbidity with every single unit of red cell transfusion that is given to patients. So the first part of this talk is going to look at fibrinogen as a cause of coagulopathy, and I'm going to generally present clinical data. So most of my talk is going to talk about trauma, and I'm also going to highlight some differences with postpartum hemorrhage in relation to how that compares with trauma. So where did all of this start? It started just over 14 years ago, where two separate publications were reported. One came from the UK, one came from the United States, where they looked at observational data in several thousand patients that demonstrated that in trauma patients, 25% of patients who came into hospital had a coagulopathy, and at the time that was generally viewed as a prolonged prothrombin time, but could also be a prolonged APTT. But if you had two identically injured patients and one of them had a prolonged prothrombin time, that patient was 3 to 4 times more likely to die, significantly more likely to require a massive transfusion. And if they did die, their death usually was immediately from bleeding in the first 6 hours, and later on was from multiple organ failure or acute lung injury. The classic view of coagulopathy up until about 15 years ago was that actually we made people coagulopathic by what we did to them after they started bleeding. So that we would give them lots of clear fluids, crystalloids and colloids, and we would give them red cells that had no plasma in it, so we diluted out of their coagulation factors. We gave them cold products and therefore made them more coagulopathic. It's quite clear, however, from the work that's been done in trauma that this isn't the case. There have been many observational studies that have been taken in the field at the site of trauma within half an hour of patients being injured that have demonstrated that those patients who've received no blood, no fluids, that they are coagulopathic as per a prolonged prothrombin time at the time of injury. I haven't got the time to go into all of the underlying things that happen in trauma, but there are two significant differences or abnormalities that are thought to be important at the moment in the development of traumatic coagulopathy. The first, many of us will have heard about it yesterday from Professor Hunt, is that the association of increased fibrinolysis in patients with trauma, and the CRASH-2 data have certainly demonstrated the clinical importance of using antifibrinolytics in this setting. The second important thing that happens in the coagulopathy of trauma is the reduction in fibrinogen level. And we know that fibrinogen, as you all know, I'm not telling you anything new, plays an enormously important role in hemostasis. It binds platelets, it is the substrate of thrombin and therefore produces a stable clot, but it is also the target for fibrinolysis, and so is a central protein in effective hemostasis. So what do we know about fibrinogen in major hemorrhage? We've known for 20 years that fibrinogen is one of the first proteins to fall in major blood loss. This was a study undertaken that looked at the clotting factors in patients who had major surgery and what happened to them if they had significant blood loss, and fibrinogen was one of the first proteins to fall to a significantly low level, which at the time was viewed to be a level of less than 1 gram per litre. What do we know about what happens to fibrinogen in trauma? We undertook, in a prospectively collected study, we looked at patients that came into hospital who had blood samples taken at the time of admission, and at the time, the eligibility criteria for this study was patients that had suffered trauma, who had come into hospital within 2 hours of their injury and who had very little fluid prior to blood samples being taken. And these patients were seen to have, who were coagulopathic and who were bleeding, significantly lower fibrinogen levels on hospital admission comparative to those patients with similar injuries but who were not bleeding and not coagulopathic. We looked at around 500 patients, and what we were able to demonstrate was an association between admission fibrinogen level and mortality, so that a lower fibrinogen level on admission was an independent predictor of both 24-hour mortality and 28-day mortality. So although this doesn't demonstrate any causal effect of fibrinogen, it demonstrates an association, and perhaps a hypothesis can be generated from these data. What we also went on to do was, because patients that we admitted into this observational study, we looked at their blood results during active hemorrhage. And so they had blood taken at admission, and the majority of these patients didn't have any transfusion prior to being entered into the study. So we took blood on admission to hospital, then after 4 units of red cells, 8 units of red cells and 12 units of red cells during that active hemorrhage. Some of them will have had plasma or platelets in those intervals, and some of them had none. And the patients in the black boxes had no fibrinogen, and as you can see, their fibrinogen levels, as you would expect and predict, fall quite precipitously during active hemorrhage if the fibrinogen isn't replaced. There have been other studies done, particularly in a porcine model, to look at what happens to fibrinogen during trauma. And there are groups in the States in particular that have shown that with pigs, if they are cooled, you get an increased fibrinogen breakdown. If they are exposed to acidosis, fibrinogen levels are not, the production of fibrinogen is reduced. And there are some data from human patients that if you give those patients colloids, which used to be given as one of the standard treatments for major hemorrhage, there was a dysfunctional polymerization of fibrinogen. And very recent data that has been looked at in the States has also demonstrated in trauma patients that the actual coagulopathy of trauma alters the oxidation of methionine residues of fibrinogen, and again that alters fibrinogen polymerization and is thought to perhaps produce poorer functioning clots. How does this relate to other settings? I'm sure all of you are aware that over the last 10 years the treatment for major hemorrhage has followed the work that's been done in trauma, and we're now looking at using empiric therapy with plasma, with red cells up front, and part of this has been driven by a lot of the data that has come from military and civilian trauma data. And what I wanted to just highlight was that actually we are beginning to understand that different patient groups with major hemorrhage and coagulopathy are perhaps not the same, and we perhaps need to take a step back and think about how we're treating them. You all know that during pregnancy, coagulation factors change so that by the time a woman reaches term, she's able to deal with the hemostatic insult of delivery. In particular, fibrinogen levels, VWF levels and factor VIII levels rise, but at term, the normal fibrinogen level of a lady should be somewhere between 4 and 6 grams per litre. This does not equate to a trauma patient where on average that patient is a young man in his late 30s who generally has a fibrinogen level of 2 to 3 grams. So we're not dealing at the start with the same type of patients. What do we know in pregnancy and postpartum hemorrhage? Similar things to that which we know in trauma. Fibrinogen appears to be a good predictive indicator of whether someone is going to do badly. This was a study that looked at patients at the start of their postpartum hemorrhage, and a fibrinogen level was one of the best independent predictors of how well someone or how badly they were going to do, so that if the fibrinogen level was less than 2, patients had 100% positive predictive value for having a severe postpartum hemorrhage, comparative to if their level was greater than 4, where they were generally not likely to have a significant postpartum hemorrhage. Another study has also demonstrated in 18,000 patients a very similar set of data that shows that your fibrinogen level is inversely related to how much blood loss you will get at the time of postpartum hemorrhage. However, unlike trauma, where it's been shown in multiple observational studies that the fibrinogen level on admission for patients that are coagulopathic really falls between 1.5 grams and 1.6 grams and is very tightly, the confidence intervals seem to be very tight in lots of different publications. For postpartum hemorrhage, it doesn't seem to be the case. Trauma patients have coagulopathy that happens very rapidly, and in postpartum hemorrhage, they seem to be separated into two groups, those that have coagulopathy early and those that have it late. And there was a very nice paper published from Laura Green at the Royal London in 2015 that looked at fibrinogen levels in 277 major hemorrhage patients with postpartum hemorrhage in the UK. And this map at the bottom, I don't know if you can see it very well, but what it looks at is in the dark line, looks at the nadir of the patient fibrinogen levels, and the sort of grey line looks at the fibrinogen level at the start of postpartum hemorrhage. And what you can see is that in cases with postpartum hemorrhage due to abruption, 100% of patients will have low fibrinogen levels at some point during their postpartum hemorrhage. Whereas if you compare that to trauma or atony, you're looking at a very different patient group. And this is suggesting to us that perhaps we need to be thinking more about etiology for these patient groups than, oh, they've got major hemorrhage. So these data are coming out, but we don't yet have all the data. So what about fibrinogen as a treatment for coagulopathy? Just looking at postpartum hemorrhage to start with, there are multiple small case series that demonstrate that if you treat somebody that has postpartum hemorrhage with either cryoprecipitate or with fibrinogen concentrate, that there seems to be a fairly good response and the bleeding appears to be diminished, but these are retrospective case series and people don't tend to publish negative results. Is there any difference if you use fibrinogen concentrate or cryoprecipitate in these patients? And this study looked at 77 cases of major obstetric hemorrhage, and the bottom line from this study is that if you give the same quantity of fibrinogen, whether it's in the form of cryoprecipitate or in the form of fibrinogen concentrate, there is no difference in the blood increment in your fibrinogen level. Other studies have demonstrated in patients with massive hemorrhage, some of which have got obstetric postpartum hemorrhage, that there is a reduction in blood transfusion allogeneic usage if you use fibrinogen concentrate to treat the major hemorrhage with red cells, FFP and platelets as well. But again, you'll note that this is retrospective and there are only 43 patients in this study. Have we got any higher quality data? At the moment in postpartum hemorrhage, there are 4 RCTs that are either being completed or are ongoing. The only completed study is from Denmark in 250 patients, where patients with any type of postpartum hemorrhage were given 2 grams of fibrinogen or placebo. Now 2 grams of fibrinogen is going to raise your fibrinogen in the blood by about possibly 0.25 or 0.5 grams per litre, so isn't going to elevate it particularly high. There was no difference in their primary outcome, which was the allogeneic blood product usage. If you were to speak to other people that know about postpartum hemorrhage, there is a question of whether they didn't A, give enough fibrinogen concentrate for these patients, and B, were they giving them to patients that already still had fairly high fibrinogen levels because they weren't checked prior to being given fibrinogen concentrate. There are 2 other studies that are ongoing in France and in Finland, and I think haven't recruited many patients to date. In the UK, Professor Peter Collins in Cardiff is leading a study which has come out of the back of this observational study called OBS1, where he looked at 350 patients observationally who had postpartum hemorrhage, and what he was able to demonstrate was that both Klaus fibrinogen and FibTem, so Rotem levels at 5 minutes, were able to predict those patients that were going to bleed significantly, either to 4 units of red cells or to more than 8 units of red cells. And he used these data to go on to the clinical trial that he's currently running across the UK called OBS2, where he's randomising 60 patients between either fibrinogen concentrate or placebo, but he's doing it unlike they did in Denmark via a Rotem-guided algorithm, so that patients, if they have postpartum hemorrhage, they're entered into the study, they then have a FibTem result taken, and if that FibTem result shows a level of 16 millimetres or less, which equates to a Klaus fibrinogen of around 3, they then can enter into the study and receive either placebo or fibrinogen concentrate. And it makes more sense to me to do that when you have a patient population that seems to be quite distinct and divided into 2 groups, those with lower fibrinogens and those with higher fibrinogens. This study, as I understand, is nearly coming to the end and again has a primary endpoint of allogeneic blood transfusion. So what about trauma? And this is the bit that I know in a bit more detail. When I undertook my MD, I was lucky enough to be part of a large NIHR programme grant, and part of that programme grant looked at the usage of transfusion products across the UK in major trauma and centres and trauma units. Now, this was in 2009 to 2011, and so this was at the early stage of us giving empiric therapy for these patients. However, what I want to draw your attention to in this large group of patients was that on average, if the patients were going to get cryoprecipitate, they got it at 3 hours after hospital admission. And on average in the UK, it takes 60 minutes for a patient to get from the scene to hospital. This graph at the bottom shows you those patients that died in this cohort, the percentage of those patients that died and when they did that. And more than 50% of the patients that died within 3 hours of hospital admission, by which time they on average would not have received any fibrinogen concentrate in a more concentrated form. So what evidence have we got that treatment with fibrinogen might improve outcomes? The first is a retrospective observational study undertaken in 250 military patients now 10 years ago, that showed that if you looked at their major hemorrhage therapy that they received and you divided the patient group into patients that either received no fibrinogen or received a bit of fibrinogen in their replacement therapy, their outcome was significantly different. So with no fibrinogen, they had poorer outcome. The MATTERS-2 study was published a few years ago, and this looked at military patients from the UK and the US and demonstrated, again in quite a large number of patients, that cryoprecipitate and tranexamic acid separately improved outcome, but if you gave the two together, outcome improved further. Again, these are observational and retrospective analyses. In the UK, we went on to use these data to run a small feasibility randomised controlled trial, which we published a couple of years ago, looking at whether we were able to give cryoprecipitate as fibrinogen replacement rapidly to patients who were coming in and exsanguinating. And this was done at the Royal London and in Oxford, and we compared we randomised patients to either receive standard major hemorrhage therapy or standard major hemorrhage therapy plus 2 pools of cryoprecipitate. And it was a feasibility study, and the numbers were small, but we demonstrated that we were able to give patients cryoprecipitate early and rapidly, which was our aim, because there are multiple things that go on which can prevent cryoprecipitate being given quickly. We were also able to demonstrate, and please note these are small numbers, but we were able to demonstrate that in the patients that received early cryoprecipitate, we were able to maintain their fibrinogen levels during active bleeding at least 2 grams per litre. But in the patients that didn't receive early cryoprecipitate, their nadir fibrinogen on average was 0.8 grams per litre. Secondary endpoints, and this is absolutely not powered to tell you anything at all, but the mortality rate in the patients that received early cryoprecipitate was 10%, and in those that didn't receive early cryoprecipitate was 28%. It certainly showed that there was no reason not to go on to a larger study, but doesn't tell us anything other than that. However, what do we know? What we are working towards a larger interventional study, and we need to think about maximising how we develop that study. Do we know what we should be aiming for in terms of fibrinogen levels? And the answer is really no, we don't. These are probably the best data that we have. This is using our prospective data that we've collected across 6 sites in Europe, where we've got 3,500 patients. And we've looked at how does their fibrinogen level relate to outcome. And these are admission fibrinogen levels. And what it seems to demonstrate is that a fibrinogen of around 2.4 grams per litre has the lowest mortality associated with it. There were some very clever statistical tests that did that. I don't understand how they did it, but perhaps it's the only data that we have to give us some indication of where to aim our fibrinogen levels. In the UK, we tried to maintain momentum while we go on to a very large interventional study, and so we have just completed EFIT, which is a multi-centred UK study led by Oxford, where we looked at the use of fibrinogen concentrate at a higher dose of fibrinogen, so 6 grams, in the same group of patients as cryostat. And we are just cleaning the data now and are about to start analysing it. The most gratifying thing about running this study compared to cryostat a few years ago is that we closed early by about 10 months. We were expecting to take 20 months to do this, and we did it in less than 10 because of the enthusiasm of the emergency department and the trauma units across the UK. And so we'll hopefully have some greater information about fibrinogen concentrate in the near future. There are 4 other ongoing clinical trials that have looked at fibrinogen replacement in trauma. They're all small, and together we will have around 300 patients that we will use in a meta-analysis to see whether we can take any inferences in terms of clinical outcomes. Where are we going with this? We have applied to HTA for a large interventional efficacy study looking at mortality, and we are 9/10 of the way to getting that money. So hopefully by the summer we will be starting to develop the getting sites across the UK and the States and possibly South Africa as well to look at randomising adult trauma patients between 3 pools of cryoprecipitate, so again 6 grams of fibrinogen compared to placebo, and the primary endpoint will be mortality. We have applied for money for 1,700 patients, and so we are hopefully there. But although that will be important, and when you ask patients and staff what is the most important thing about how does fibrinogen work, they want to know what the mortality, whether it improves mortality. We have so many more things that we need to find out. We need to know about the thresholds of fibrinogen. We need to compare what happens with cryoprecipitate compared to fibrinogen concentrate. And we also need to work with other groups looking at the coagulation changes across different patient groups, because it's becoming increasingly apparent that what happens in trauma is not directly translatable to what happens in other patient groups. And I'll finish there.